Svanfeldt, sorry, from the Division of Health and Social Care. And we're very, very happy for you to taking your time and visit to take part in this visit. Erik and Jesper, please introduce yourself closer and your respective areas. Thank you.
So, hello, welcome. My name is Erik Svanfeldt. I work as International Coordinator at the Health and Social Care Division, which means that I work with all kinds of international issues, including being responsible for some of the study visits that we receive from not just Ukraine, also from other countries. I will start by giving a short introduction to Swedish municipalities and regions, this organization, SALAR, and also tell about the municipal and regional responsibilities for health and social care.
Yes, my name is Jesper Ekberg. Did you enjoy the view outside?
Yeah, killed for it.
Some coffee with the sunshine. It's not every day it's sunshine here, you know, so good timing. Yes. My name is Jesper Ekberg. I work at the same division, but more into public health issues, social care, and also how we do the we're working a lot on a shift to integrated and personalized based care. So I will go more into that shift and how we do that. All right.
I just wanted to say that we have already introduced you to the speakers, so they know who you are, but of course, along with your questions, you may present yourself.
Perfect.
So Sweden consists of 290 municipalities and 20 regions, very different in size, both geographically and when you look at the amount of inhabitants. They all have the same responsibilities, doesn't matter what size. As you can see, the municipalities are geographically bigger in the north than in the south. It's because most people live in the south. Sweden as a whole has like 10.5 million inhabitants, and 1 million live there and the rest in the south. And along the way you will hear that sometimes hear that we have 21 regions. And it's because this island, Gotland, is a municipality in the region at the same time. So Islam, sometimes we count it as a municipality, sometimes as a region. Sweden, as said, has 10.5 million inhabitants. In the last decades, we have seen an increase of the population. We passed 9 million in 2004. We passed 10 million in 2017. The main reason for this is immigration. But we have also, until recently, I would say, had positive birth rates as well. But the main reason for the growth of the population is immigration. The population, the growth has taken place in the urban areas. Smaller municipalities, rural municipalities have, to a large extent, have had the same population. Some of them have also experienced a decrease in the population. But the big municipalities, they have increased. So Stockholm, city of Stockholm without suburbs, that now have about 1 million inhabitants, 20 years ago had 800,000 inhabitants. The region of Stockholm, I know, 20 years ago had like 1.8 million inhabitants, and now it's 2.5. So the growth takes place in the urban areas, not in the rural areas. In Sweden, the municipalities and regions are responsible for a big part of the public services, schools, healthcare, social care, etc., etc. I will come back to that later. At the same time, Sweden is a unitary state. It's not the federal state. The unitary state, which means that the national government always has the last say, so to say, or the parliament has the last say. But at the same time, we have a strong tradition since many years of a strong local self-government, which means that things don't work the same in the whole country, because different municipalities, different regions take different decisions, political decisions. What gives the municipalities and regions such a strong power, I would say, is the fact that they can levy taxes on incomes. And most people in Sweden just pay income tax to the municipality and the region, not to the national level. It's just above a certain income that you also pay, on top of the local and regional taxes, also pay 20% tax to the national level. And this fact that in each municipality, each region can decide how much tax the inhabitants should pay, gives them quite a big power. If we look at the financing of the services, 2/3 of the incomes that the municipalities and regions have comes from this tax that they decide themselves, income tax that they decide themselves. More than 20% of the incomes come from state grants, also taxpayers' money, but it comes from the state to the municipalities and regions. Then the inhabitants have to pay fees for some services, but the fees and charges represent a very small part of the budget. About 3% of the regional budget, about 5% of the municipality budget comes from fees and charges. So the main income is taxes. In Sweden, as I said, the municipalities and regions, they have all the same responsibilities, but they don't have the same populations. Some regions or some municipalities have more wealthy inhabitants than the other municipalities. The social needs are not the same. You will see that in some municipalities you have more of an elderly population, normally also with lower incomes. And to give the municipalities and regions more equal conditions to provide good services, we have a system for local government financial equalization. It's a system run by the national government, the national parliament, which means that some municipalities pay money to other municipalities, some regions pay money to other regions to give more equal conditions. It's good to know that we have this system because the amount of tax we pay is very different. Normally we pay on average like 32% of our salary to the municipality and region, but it's between, if we look at the individual municipalities and regions, we pay between 29 and 35 depending on where we live. So it's a big difference in taxes between different parts of Sweden. The sector, the municipalities and regions, employ a lot of people. The last figure I got from 2024 is that regions and municipalities employ more than 1.3 million people, which corresponds to about 25% of all Sweden's employees. The municipalities employ almost 1 million and the regions more than 300,000 people. And interesting also is that women represent more than 70%, 75% all the employees. And behind this figure is the fact that municipalities and regions are responsible for sectors that employ a lot of women. A lot of women working in preschools, schools, elderly care, healthcare, etc. So men in Sweden tend to work in the private sector, women to a larger extent in the public sector. So this is the basics about our members. Now I'll say something about our organization here. SALAR, which is the English short word for Swedish Association of Local Authorities and Regions. It's an interest organization gathering all municipalities and regions. Membership is voluntary. They don't have to be members, but they have all decided to be members. So that all of them are members. To finance our activities, the basis is the fee that all the members pay, which is based on the tax base, which means that bigger members with many inhabitants pay more than smaller members with fewer inhabitants, and members with more wealthy inhabitants pay more than members with less wealthy inhabitants. I don't say poor because I don't think the difference is that big, so I always say wealthy and less wealthy. That's the basis for financing our organization. It's a fairly new organization, or at least now it's 20 years old about. In the past, we had one organization representing municipalities and one organization representing the regions, but they merged into one organization in a process between 2003 and 2007. And I think that was one reason for it was to make municipalities and regions to cooperate better, to have the same umbrella organization instead of fighting each other. It's to cooperate, and I think it was a smart decision, because I used to work both in the municipality and in the region, and I think it made good sense to have a common interest organization. So what's the mission of our organization? First of all, we work as an interest organization representing all the municipalities and regions. We discuss, talk to, but also cooperate with the national government, the national parliament, national agencies. But we're also working towards European Union. So we have a small office with like 3 or 4 people in Brussels as well. A big task is that SALAR is the biggest employers organization in Sweden. Our organization negotiates with the trade unions. Not so much about, not directly so much about salaries, because in Sweden we also have individual salaries in the public sector. So a lot of salaries in the public sector are set on local level and not on national level. But the framework for further discussions on regional local level is set on national level. So our organization negotiate with the nurses union, doctors union, teachers union, etc., etc. The third mission is to offer services support for operational development. In not least in healthcare and social care, we run a lot of projects. The aim is to provide the services and improve healthcare and social services. And finally, one mission is also actually to provide an arena for our members to meet and encourage dialogue and cooperation. And it's a political organization. Our board consists of local and regional politicians, and they are elected by a Congress every 4 years. And I also think it's worth mentioning, although the board consists of politicians from many different political parties, from the left-wing parties to the right-wing parties, our organization is very much a consensus organization. Politicians from different political parties tend to cooperate fairly well, I would say, here on the board. Even those cannot cooperate at home. Once they are here, they cooperate better, so to say. Now, it's not for us who work here and are not political. It's not that big issue when we change majority, I would say. It's just in very ideological issues, and there are some very ideological issues where we can see that the majority and the minority have really different opinions. But in most issues, there is a consensus, I would say, between different political parties. And that, from my point of view, that's a strength for our organization, that we have this good political climate here. That's about organization. Now, I will say something about local and regional responsibilities when it comes to healthcare and social care. In Sweden, the regions have the main responsibility for health and medical care, and they are also responsible for dental care for young people and kids. In Sweden, we have free dental treatment for children and young people aged 3 to 19. The municipalities, they are responsible for social care and social assistance, but they also have some responsibilities for healthcare. And you will probably notice this when you go out there and see what's happening on the floor, so to say. The municipalities are, by law, responsible for primary care in special housing. Primary care services delivered in, for example, nursing homes. It's a municipal responsibility. In 20 of 21 regions, in the whole Sweden, except for Stockholm region, the regions and the municipalities have agreed to transfer the responsibility also for primary home care in regular housing to the municipalities. This is not by law, this is by agreement between regions and municipalities. But in Stockholm, the region and municipalities have not been able to make this agreement. So this means that the primary care, the municipalities are responsible for also to deliver primary home care for those who live in regular housing. Finally, but there is one interesting thing about this, is that municipalities normally cannot employ medical doctors. That's still a regional responsibility, so to say, which means that municipalities have to contract a primary care center or someone to deliver these medical services. And this has been an issue for many years, if we should continue like this or not. But that's the case. The only doctors that the municipalities can employ are the school doctors, because since long, municipalities are responsible for school health services. So the school doctors are employed by the municipalities. Social services, then, a few words about that before we go to healthcare. The law says that municipalities are responsible for providing support and assistance to people in vulnerable situations. And any such support or assistance is to be based on the needs of the individual. And here it's very important. It's the municipality that assess the needs and take the decisions. Even if you have a private provider, it's the municipality that takes the decision. Here's a difference between social care and healthcare, because in healthcare, a private doctor that is contracted, linked to the public system, he can take a decision what's the needs, medical needs of the patient. But it's not the region that takes this decision necessarily. But in social care, it's the municipality that takes this, to make this assessment inside the needs. And the social services include individual and family care, including economic assistance if needed, elderly care, and support to people with disabilities. I will not go into detail about this, but I can say that a general approach or philosophy is that to make it possible as long as possible for people to live in regular housing. There is special housing for those who need it, because some people do need it, but we have all kinds of support to make it possible for people with disabilities or elderly people to live in a regular housing instead of in a special housing. So something about the Swedish healthcare system then. The Swedish system is mainly tax financed and decentralized, which means that a lot of things are decided on local or regional level, and things don't work always the same in the whole country. I will show you later an example of this. The regions finance most of the healthcare and also provide most of the services. But here we can see a difference between inpatient care and outpatient care. When it comes to inpatient care, almost all hospitals are run by the regions. There are some exceptions where the regions have contracted private providers to provide the service. For example, we have a big hospital here in downtown Stockholm called St. Göran's Hospital, which is run by a private company, but on contract with the region. So in inpatient care, most of the services are provided by the regions themselves. But in outpatient care, we see much more private providers. And in dental care, we have since long had a lot of private dentists, and that's because most of the financing, when it comes to adults, is private as well. So that makes sense. The Swedish system covers all residents, everyone living here, but as I said, dental care for adults aged 20 and over is mainly financed by the patient. So here we have a big difference between medical care and dental care. Dental care is to a much larger extent paid by the patient, and the subventions that exist are national. It's a national system for subventioning dental care for people aged 20 and older. And the regions are also responsible for financing healthcare even if it's given outside the region. So the region is finance their healthcare they provide for their own citizens, own residents, but they also provide services. They also finance healthcare services provided by private providers. That is included in the tax finance system. They also finance services for their residents that is provided in another region. So, for example, if someone from Västerbotten, where you will go, a patient from Västerbotten is sent, for example, to Stockholm for care, Västerbotten pays. Also, since some years ago, the regions are responsible for financing healthcare that is provided in other European Union or European Economic Area countries, EEA countries, or it's Liechtenstein, Norway, and Iceland. So this means that if I, as a resident of Sweden, go, for example, and receive healthcare in Germany or in Greece, in the end it will be, and it's healthcare that should be subventioned by Sweden. It's in the end the region where I live that pays also this care. So the region is actually the region is actually responsible for financing healthcare provided also outside the region in Sweden, but to some extent also abroad, but not in all countries.
Хотіла просто спитати, пацієнт може сам сказати, я хочу поїхати в Німеччину отримати охорону здоров'я, чи хтось його напряму скеровує?
Say, I want to go to a different country to get healthcare, or he's referred. How it works?
Swedish patients.
Шведські пацієнти.
Okay. It comes back. Swedish patients, if we talk European Union member states and Switzerland, Liechtenstein, Norway, and Iceland, we can. There is a European legislation that makes it possible for us to go abroad. We don't need a permission before going. We can go without permission. But we pay the costs ourselves, and then we can come back and ask for reimbursement. And if it's a kind of care that should have been included or subventioned in Sweden, then we have the right to get reimbursement. Yes. But when it comes to this, if we go on purpose to get healthcare, we call planned healthcare. It's the European, European Union member states, Norway, Iceland, and Liechtenstein. If we happen to get sick when we are there on a holiday or in work or something, we can also get subventioned healthcare in Switzerland and United Kingdom. And there are bilateral agreements with a few other countries in the world, but like Australia. But the main legislation is a common European legislation. But anyway, we always tell people, have a travel insurance that cover also medical costs, because you never know. You never know. And what is very important to tell tourists going from Sweden abroad is that even if the healthcare, if you go to Spain and get ill and have to be hospitalized, even if the healthcare is covered by the system, the transportation back to Sweden is not. So if you cannot go with an ordinary plane, you have got special transportation. It's on your own expense, and it's very important that you have a travel insurance, even if we have this system. It's very, very important. So in Sweden, Sweden has about 1,200 primary care centers all over the country providing primary care. This figure has increased in the last years. So we have seen an increase in the last decades of primary care centers. We had and this figure is from 2022, 66 hospitals with emergency services day and night. I said we had because I believe that since then there have been even, the number is less today because we have seen a reduction of emergency hospitals with full services in the last decades. We've seen it, and this has taken place both in urban areas and in rural areas. Stockholm used to have, some decades ago, used to have many small emergency hospitals that don't exist. They exist sometimes as hospitals, but they don't provide emergency services day and night. So here we have seen a decrease of emergency hospitals, increase of primary care. At the same time, it's also seen a decrease of hospital beds. Sweden is one of the countries with the lowest number of hospital beds in the whole Europe. The most developed services, the high specialized healthcare, is provided by 7 university hospitals in 9 locations. It's 9 locations because we have seen mergers in this area. So Stockholm actually has 2 campuses, but it's one administration, it's one hospital formally. And these hospitals provide the most specialized healthcare. As I mentioned before, almost all emergency hospitals are managed by the regions, but the share of private providers of outpatient care varies significantly across regions. And here, this shows that things don't work the same in the whole country. This shows the proportion of private primary care centers in different parts of Sweden. And behind this figure is, of course, I would say, different political opinions when it comes to private provision of primary care in different parts of Sweden. Stockholm, more than 70% of the primary care centers are nowadays run by private providers. The financing comes from the region. The fees are the same for the patient, doesn't matter for the patient, but there are a lot of private providers, private primary care centers in Stockholm. In the other end, you have Västerbotten, where you will go with less than 15%. In the past, the regions could really decide themselves if they wanted to have private providers or not. But in 2010, we had a national reform which made it mandatory to open up for private providers that met the conditions, met the requirements to establish and get financing from the region. So even those regions that at that time had no private primary care center had to open up. But still very big difference. But generally, we can also see that private providers normally tend to establish in urban areas, in big municipalities, not in the small municipalities. But there are exceptions. It's not always the case. But we can see that generally that private providers tend to establish more in the urban. So a few words before I get you get the floor. I will say just a few words about what the region and municipalities do and what the state is doing when it comes to responsibilities. Because I always get the question about this. So what's the role of the state? The regions or municipalities, they decide on organization and delivery of healthcare services. They normally take these decisions. What to deliver and when. They decide on mechanisms for paying the providers. The way the providers get their money is not the same in the whole country because each region has their own system. They decide, as I said before, about the income tax rate. They set the patient fees. The fees that the patient pay is different in different regions and different municipalities. Although there is a national high cost protection and maximum fees, so when it comes to inpatient care, the regions cannot charge more than, I think it's now 130 Swedish kronor per day or night. And there is also a maximum amount of money that patients pay for outpatient care in a year. And they also decide user charges for prescription aids. And here we can see a big difference between different parts of Sweden. How much you pay if you need a wheelchair or other equipment for people with disabilities. The state, the national level, legislates, establishes principles and guidelines, distributes responsibilities. In the end, it's the national level that decides who's doing what. They have a very important supervising role. They are responsible for supervision of these services. They allocate government grants. They decide on local government financial equalization that I mentioned before. They decide on national high cost protection and maximum fees. So that is how to say the municipalities and the regions cannot charge as too much, so to say. Normally, the regions and municipalities decide what services to provide or not, but we have a system with licenses for national specialized medical care services. For extremely highly specialized healthcare, or very highly specialized healthcare, there is a national system for deciding which hospitals should provide the services and others are not allowed to provide it. I will just give two examples. Heart transplantation. There is a national decision that has said that hospital and that hospital, they can make heart transplantations, the others not. And of course there is a quality reason for this. Another example, severe burns. The University Hospital in Linköping, University Hospital in Uppsala, they are responsible. They have special centers for taking care of people with severe burns. The others cannot. And of course they have all the equipment, but they also have the staff for providing these services. Finally, the state issues licenses for healthcare staff to practice. If you want to practice as a nurse or a doctor or physiotherapist, or there are many other occupations as well, you need a license from the national agency. Finally, just a few words about issues on our agenda. One is, of course, to reduce not just health gaps, but also inequalities in healthcare. We can see that there are quality differences between different providers. There are all kinds of projects and work going on this. Shortening waiting times, also a big issue, has been for decades in Swedish politics. How to shorten waiting times. Even if quality is good, we can see that some people still have to wait for some treatments. Digitalization of welfare services, big issue in Sweden, like in the rest of the world, I would say. Crisis management and civil preparedness. This became an issue like 10 years ago. We realized that we had to be prepared for worse times. I would say that one reason for why it appeared on the Swedish agenda was the Russian occupation of parts of Ukraine. Then this became even more on the agenda because of COVID. Even more because of COVID-19, but it was already there before. But the work became even more important. So this crisis management covers all kinds of crises, so to say. Big issue in Sweden, like in many other countries, is recruitment, retention, and education of employees. How to recruit and keep healthcare workforce, and employ and educate enough of them. Sweden has, not least when it comes to medical doctors, nowadays we have quite a lot of medical doctors that have studied abroad, have a diploma from abroad, both people born and have people that have their roots abroad, and Swedish people that go abroad and study and come back. For example, very popular go to Riga in Latvia, go to Poland, Hungary, Romania, but also, there are also other countries. One big issue that you will come back to is the conversion to primary care system with emphasis on prevention and person-centered services as close as possible to the patient. In Swedish, god och nära vård, which means good and close care, if we translate it word by word. And finally, one issue is the economic issue. Not just on short term, but also on the long term, how to fund all the finance all these welfare services, not just healthcare, other services as well, because of the demographic changes that we can see. Even in Sweden, even in Sweden now, we started to talk about that there are not enough kids born. We can see we need more elderly care centers. At the same time, we can see preschools and schools are closing because they're not kids enough to fill them. That was my presentation. So, I give the floor to Jesper, but maybe one question.
Maybe one question.
One question before.
Okay. У нас в Украине сейчас происходит процесс, попытка разделения полномочий между рівнями публічного врядування, вибачте, між рівнем громади, базовим уровнем, між регіоном, областю і між державою. Готується законопроект. І йде цей процес дуже важко, оскільки є окрема підгрупа, яка займається охороною здоров'я і розмежуванням повноважень між рівнями публічного врядування. Чи є у вас законопроект, який ми можемо взяти і вивчити, який встановлює розмежування повноважень між рівнями публічного врядування, між регіонами, муніципалітетом чи державою? В сфері охорони здоров'я. Це перше. Друге.
Може, краще відповісти?
No, I don't think we have any such law. In Sweden, it's up to each municipality and each region to decide what healthcare workforce or in other sectors, what kind of competence they need. We have a discussion about how many patients should there be per doctor in primary care and so on. There are some targets, but otherwise, in Sweden we focus on something else. I would say teamwork, to make different professions work better together. And we also task shifting, that sometimes tasks that are done by doctors could be done by nurses or physiotherapists or others. Tasks done by nurses could be done by nurse assistants. We have more this kind of, but we don't tell which kind of profession should be on the individual levels. But as I mentioned before, we have this debate about if municipalities should be allowed to employ doctors or not. They are allowed to have school doctors, but not employ doctors working, for example, in the primary care, which they are responsible for. Elderly care, yes.
Elder,
Ні, не первинної медицини, а догляд за людьми похилого віку.
То есть нет никакого нормативного акта, где зафиксировано,
There is
что
no legislation that
а,
clearly
первинна медична допомога
that
і
primary
догляд
care
за людьми похилого
and
віку – це
elderly
виключно
care
муніципалітети,
it's exclusively
а стаціонарна медична допомога
of
і
municipalities.
лікарні – це
Inpatient
регіональна.
care and hospitals is the competency or responsibility of the regions.
Is it
If,
lower?
The law, do you have a law that says that? You had a slide
yes,
about responsibilities.
the municipalities are responsible for
Муніципалітети відповідають,
the municipalities are by law responsible for
відповідають
the provision of primary care
за
Є закон, так, закон.
медицину,
in special housing, which can be both
спеціальних
elderly care and
догляду.
special housing for people with disabilities.
Закладі догляд за людьми з інвалідністю, за літніми людьми і там.
Ну, от
Yes,
по закону
so
такі
there is a
питання.
law about
Закон.
that.
There's-
Yes.
Can we receive this law to read?
I think a
Okay.
Yes.
And the second most questions, вибачте, це українською мовою.
Ні, кажіть.
А найбільше запитання, коли ми розділяємо ці повноваження, вони мають бути забезпечені ресурсами. Тобто фінансово. Тоді чи існує, можливо, ви надасте нам приклад, методології розрахунку соціального нормативу? Як розрахувати, скільки грошей потрібно для забезпечення повноважень на рівні муніципалітету або регіону, якщо вони розділені?
Якщо ці повноваження розділені.
Якщо ці
I would
повноваження
say
розділені, яким
there is-
чином розрахувати, як
there is not one model
Немає єдиної моделі.
because each region have their own system, even if they some have
Будь-який приклад.
similar systems,
Будь-який
but
наш.
basically they have their own system for distributing money and decide how much to give the providers specific services.
Надавати кошти певному провайдеру за конкретні послуги.
Yes.
ми зможемо отримувати інформацію, можливо, з якогось регіону,
Це-
яким
а-
чином
а-
вони здійснюють такі
because-
розрахунки потреб і потім
Yeah,
фінансування.
that would be very interesting for us to obtain during a study visit, kind of a more concrete example how they calculate, how they know how much money they should.
Make assessment.
You should ask when you go to Västerbotten.
Okay.
Västerbotten, поїдете,
Yes.
проведете їх запитання.
Yeah, they could tell about
От
their
вони
system.
можуть розказати
But they
про
have
свою
one
систему.
system, it's not
Але це
not
буде
the same in the
одна
rest of the
система.
world.
Це не означає, що
Sorry, can I just come in? I think the word competence was a bit misleading there in the first question, because in Swedish, competence is to do with the capacity of the people working there. But I think it's clearer now, right? The focus is on the transfer of the
А він каже, що
responsibility that
можливо
is given to
переклад, іноді ми
municipalities or regions
повноваження
for healthcare.
перекладаємо як responsibility, відповідальність, іноді як competency було
Is
тут
that
на
the
слайді.
question?
І
Так.
тому він трішечки не дуже зрозумів, коли я сказала competence.
Мгм.
Він подумав, що це компетенції чи компетентності фахівців.
Повноважень. Ну, да.
Так, звичайно.
Дякую. Костянтин Надутий, Асоціація сімейних лікарів України і Асоціація експертів України, медичних експертів.
Healthcare experts.
Питання таке. Скажіть, будь ласка, чи існує в Швеції
Question is,
професійне самоврядування медичних
so
працівників?
whether in Sweden you have professional self-
І яка їх роль в тому, щоб визначати право на професійну діяльність?
And what is their role in granting the right to practice?
А також можливо інші повноваження.
Maybe they have other roles.
The right to practice
It's
is
like licensing.
yes. The licensing is a responsibility for the
Ліцензування
the National Board of Health and
це
Welfare.
повноваження Національної ради охорони здоров'я і
They
соцзахисту.
they decide about licenses.
Вони
Yes.
присуджують ліцензії.
Then we have, for example, when it comes to when it comes, for example, medical doctors, there is 2 different organizations representing doctors. I don't know what's the English name for them is, but there is one called Svenska Läkarförbundet, which is more like a trade union dealing with how to say the working conditions, salaries, things like this. They are the organization that negotiate with all our organizations. But then there is another organization called Svenska Läkarsällskapet, which is not a trade union. It's more an organization about developing the role of the medical profession. They are more about they are more into how to develop the profession, discussing ethical issues and these kind of things.
Професії етичні. Є така організація. Є назви її контакти.
Ми візьмемо,
We can find the link.
Шведською, да.
Так, ми можемо вам дати посилання.
Занотуйся.
I think we have to give the floor now to Jesper. Otherwise.
And thank you.